Hello, and welcome to the Alabama Public Health Training Network. The interactions of medications to drugs and herbal remedies have the potential to decrease the effectiveness or increase the action of medications and cause some adverse side effects. Today, we will discuss ways to help identify potential drug-drug and drug-herbal interactions of the most commonly prescribed oral contraceptives and seizure medications. Thank you for joining us today. We have a program called I'll get it out in a minute, Pharmacology Update, Interactions of Oral Contraceptives and Seizure Medications to Drugs and Herbal Remedies. Please join us. If you have any questions about any of the content being discussed today, please call or email us during our broadcast. The phone number and the email address will be on your screen and will appear later in the program. Also, the handouts, sign-in sheet, and evaluations are all available online. You will need to register for this program in order to access these materials. Continuing education credits have been approved for nurses, social workers for today's program. In order to receive credit for this training, you must watch the entire program, complete and return the sign-in sheets and the evaluation tool. The content is relevant for today. The CE credit will only be awarded for a one-year time frame and will expire on March 31, 2016. Good morning. My name is Teresa Dix, and I'm a nurse educator with the Alabama Department of Public Health. And with me today is Nancy Bishop. She is the Assistant State Pharmacy Director. I will now turn the program over to Nancy. Good morning, Nancy. We're glad you're here.
Thank you. And Teresa, this title is a mouthful, but hopefully we can break it down to get the drug-drug and drug-herbal interactions more understandable. First, it's important that we look at this, the different levels of interactions. Level 1 is considered a severe interaction. The medicines that fall in this should be avoided if at all possible. Sometimes that is not possible, so rare exceptions do exist for this. Level 2, using these medications together may be contraindicated for a select group of patients. We should consider alternative therapy, and if we cannot, we should monitor the patients. Level 3 is moderate. Using these medications together may result in unintended clinical effects. Again, we should consider alternatives in therapy, and if that's not possible, monitor the patients. Level 4, using these medications together usually do not result in a clinically significant interaction. So let's look at the drug-drug and drug-herbal interactions of oral contraceptives. Level 1 contains 4 different points, one being a group of medicines. The first is, the first 2 are HIV protease inhibitors, fosambivir and Ambrisentan. I'm sorry, I'm going to struggle with these generic names, but most of you know these by trade names anyway, and you will find me kind of going back and forth between generic and trade names. These 2 are the HIV protease inhibitors, and we will see more in this group later on in different levels of interactions. The other group is the Aromatase inhibitors, which are the hormonally medicines given for hormonally responsive cancers. The third is Tracleer, which is given for pulmonary arterial hypertension. And the fourth one you probably will not see because it has been pulled from the market in the U.S. except for compassionate use. So the protease inhibitors. The oral contraceptives decrease the serum concentrations of these 2 protease inhibitors. and the metabolism of the oral contraceptives is increased by a group of the other protease inhibitors, which we will discuss later in level 2. With protease inhibitors, the patients may report breakthrough bleeding and other adverse effects, and they should be using a barrier method of contraception. The aromatase inhibitors, the estrogens could interfere with the action of these medicines, thereby decreasing which are supposed to decrease the level of estrogens and inhibit the growth of the cancer. So it's not so much that there's a drug-drug interaction, but there's a pharmacologic interaction between this group of medicines with the oral contraceptives.
Nancy, could we go back maybe just one little step and talk a little bit about protease inhibitors and just a very kindergarten, for those that may not remember how they work or what they do?
Protease inhibitors are basically the antiviral for HIV. Okay. And as we talked about, 2 are level 1 interaction with oral contraceptives. And there's a group that's in level 2 also.
Okay.
Does that help explain what you're doing?
It does. Thank you.
Okay, some of the aromatase inhibitors are listed here. Again, these are given to people who have cancers that are what we call hormonally promoted, so you want to cut the level of estrogen. Tracleer, as we said, is indicated for pulmonary arterial hypertension, and it's a significant inducer of the CYP3A hepatic enzymes. This is going to come up several times in our discussion because the oral contraceptives are highly affected by inducers, inhibitors of this hepatic enzyme. There can be up to a 50% decrease in the level of norepinephrine and up to 66% decrease in ethyl estradiol. Tracleer is teratogenic and is contraindicated during pregnancy. Again, the metaproprone, you probably will not see. It's indicated for hypothalamic pituitary adrenal suppression diagnosis, and it's only available in the U.S. for compassionate use. So that brings us to question number 1, and I think this gets back to your question, Teresa. A patient taking oral contraceptives and a protease inhibitor should always use a barrier method of contraceptive regardless of the interaction level. Is that true or false? It's true, because the most common indication for protease inhibitors is HIV. So let's talk now about the level 2 interactions. Now these are those that taking the medicines together may be contraindicated for a select group of patients, and we should consider alternative therapy. And here's this other group of HIV protease inhibitors. Again, you should always use a barrier method if you see these a patient comes in taking these medicines. You can also see some anti-seizure medications as a level 2 interaction with oral contraceptives. Tuberculosis medications are in there, as well as antifungal. We also have the breast cancer prophylaxis medications and some others such as Betaxetine, charcoal, and modafinil, as well as tenazidine and warfarin, and here we see St. John's wort and tobacco. So, question number 2. True or false? A medication listed as level 2 interaction should never be given to a patient receiving oral contraceptives. False. We could consider alternative therapy if possible, but if not, we need to closely monitor the patients. As we talked about the CYP3A4 enzymes, a lot of the interactions with the oral contraceptives, specifically estrogen, falls into this category. Estrogens are metabolized by the CYP3A4. Therefore, they're susceptible to interactions with any enzyme that induces, with any drug that induces this enzyme. The seizure medicines stimulate this enzyme, thereby causing oral contraceptive failure. The low-dose estrogen regimens are at greater risk. Patients are also at higher risk for folate deficiency and at greater risk for tubal defects when failure occurs. The anti-seizure medications are also CYP3A4 inducers. You may see a decrease in the level of contraceptive efficiency. The Tegretol and Lamictal fall into this, as well as the Topamax, and those three are commonly used for seizures. The Topamax decreases the level of contraceptive activity if the dose is over 200 milligrams per day. There's usually no adverse effect if the dose is between 50 and 200 milligrams per day. Dilantin also falls in this category, as well as fosphenytoin, which is not used much except in hospitals. The tuberculosis inducers also may decrease the level of contraceptive activity, and we see rifampin in this, which increases the elimination of the estrogens and progestins. It also increases the protein binding activity of the estrogens. 70% of women taking estrogen-containing oral contraceptives and rifampin experience menstrual abnormalities, and 6% become pregnant. And we also have listed the other two tuberculosis treatments that can be included in this. Antifungal medications, such as diflucan and griseofulvin, may also be effective. The clinical significance of diflucan is really unknown, but you may see variations in the increase and decrease of hormonal concentrations. Griseofulvin is an inducer of the CYP3A4, and you may see a decrease in the level of the efficacy of the oral contraceptives. The breast cancer prophylaxis medicines, tamoxifen, is contraindicated in most, if not all, patients. Oral contraceptives may aggravate conditions being treated by tamoxifen, as we stated earlier. The Evista blocks estrogen receptors, and it's just basically illogical to give it with estrogen. Coumadin. Generally, we want to avoid giving Coumadin or Warfarin to patients taking oral contraceptives due to the thromboembolism risk. But you have to weigh the risk versus the benefits. Keep in mind that the oral contraceptives can alter the INR, which may require a dose adjustment in the Warfarin. The products most affected by this are the ones that contain 50 micrograms of estradiol or greater. So you may want to, the addition of progestins may also increase the thromboembolic risk. Xanaflex is another one in this category, this level, and it may increase, taking these together may actually increase the Xanaflex levels. The clearance can be decreased as much as 50%, thereby giving a risk of hypotension, bradycardia, physical motor impairment, and other adverse effects. Provigil is indicated for narcolepsy. It's an inducer of the 3YP3A4, and it may decrease the level of the oral contraceptive efficiency. It also may cause failure and of not only oral contraceptives but also hormonal containing implants or devices. You probably won't see Targentin much. It is an inducer. It is indicated for T-cell lymphoma, and it also may decrease the efficacy of the oral contraceptives. Tobacco. We all know that tobacco increases the risk of the thromboembolic disease, and we all tell women to stop taking tobacco. For those that are 35 years and older, this has an increased risk, and also for those who smoke 15 cigarettes or more per day. Charcoal. I thought this might be something you wouldn't see until I started reading more about it. Evidently, people use this for all sorts of reasons, including constipation and just to clean out the system. But charcoal is also given in poisons, so it's there to absorb the medicine in the stomach. So you will have possible absorption issues with the contraceptives. If a patient does take the charcoal, they need to take it 3 hours after, but at least 12 hours before the oral contraceptive. St. John's wort is another popular herb. It's a CYP3A4 inducer, and you could have loss of contraceptive efficacy.
I did not know that.
So that brings us to the level 3 interactions. And this is where we get into a lot of medicines. Just as a reminder, level 3, using these medicines together may result in unintended clinical effects. You should consider alternative therapy, but if you don't, monitor the patients. So the first couple of slides here actually just list the medicines, and we'll break it down into category. A lot of medicines in here are the anti-infectives. This is probably the most known drug interaction of the oral contraceptives. But note that it is a level 3, which is defined, again, as a moderate interaction. These anti-infectives disrupt the normal GI flora, which causes a decrease in the effectiveness of estrogen-containing oral contraceptives. It includes several, most notably amoxicillin, ampicillin, clindamycin, penicillin, nitrofurantoin, and the sulfonamides, as well as the tetracyclines. The microlid anti-infectives may also increase estrogen metabolism, and erythromycin is included in this group. The incident of interaction between the anti-infectives and the oral contraceptives is unpredictable. We noticed in the description of level 3 that some patients may be at risk. We cannot predict which patients would be at risk if giving an anti-infective with an oral contraceptive. So this leads us to our third question, true or false. Patients should always be counseled to use an alternative means of contraception while taking antibiotics. At least for me, that's true, because for me it's a liability issue. I cannot predict which patients would be affected and which would not be. So that brings us to the seizure medicines. Lamictal is indicated for seizures and for bipolar disorder. It may decrease the hormonal level, resulting in contraceptive failure. Estradiol and mestranol may decrease the Lamictal levels, resulting in a need for increased dosing. The side effects could be dizziness, ataxia, and these may occur during the placebo off week. Progestin-only products are not known to change the Lamictal levels. Theophylline is also a level 3. It's indicated for asthma and bronchospasms. Oral contraceptives may increase the theophylline levels, resulting in a risk of toxicity. It is a CYP3A4 and a CYP1A2 substrate, and it inhibits hepatic metabolism. Cyclosporine is used for organ transplant rejection, rheumatoid arthritis, and psoriasis. It is a 3YP3A4 substrate with moderate inhibitor characteristics. This gets a little complicated in predicting its effect on the oral contraceptives. Oral contraceptives may increase the cyclosporine levels with a risk of toxicity. You also increase the risk of hyperpotassium levels. Elderpril is used for Parkinsonism. Its oral contraceptives may increase the elderpril concentrations as much as 20-fold due to the decreased metabolism of the elderpril. It may be necessary to reduce the dose of elderpril. This is a good time to talk about the dosing when it comes to medicines that can cause a change in the concentration one way or the other. Anytime a drug is started or discontinued, you may need to adjust the dose of the other one. So if oral contraceptives are started while someone is on Theophylline or elderpril, some of those very tight therapeutic concentration levels, you may need to see an increase. You may use an increase or a decrease in their dose. So that's why it's very important to monitor these patients. This drug is used for pulmonary arterial hypertension. It does have restricted distribution in the U.S., so you probably will not see it much. It is a CYP3A4 substrate. Emend is indicated for prevention of chemo-related nausea and vomiting. It does come in an injection form also. It's a minor inducer of the CYP3A4 and a moderate inhibitor with moderate inhibitor characteristics. This may seem contradictory, but it's just those unknown effects of the drug-drug interaction. CellCEP falls in the other category. It's used for the prevention of organ transplant rejection. And also, Detraline is indicated for spasticity, And there's an increased risk of hepatotoxicity with this. Doxorubicin is indicated for hypoparathyroidism. And growth hormone is indicated for growth hormone deficiency. So you may see this in your adolescent girls, usually 15 years old or 15 to 18 years old, but also growth hormone deficiency is being more diagnosed in adults too, so you may see this in adults. It does induce the hepatic metabolism, and so you may see decreased hormonal contraceptive levels resulting in failure. The herbs. Let me catch up just a sec. Echinacea inhibits the intestinal CYP3A4, but it induces the hepatic CYP3A4. Its clinical significance is unknown. The soy isoflavones have a similar chemical structure to the synthetic and natural estrogens. Its clinical significance is unknown, but use it with caution because of its similar chemical structure. That brings us to level 4. These are considered minor. Using these together may not result in a clinically significant interaction, but it's important to know about it and to monitor the patients. Included in these are the anti-diabetic medicines, the antihypertensive agents, ascorbic acid, which is also vitamin C, and you have Lipitor, as well as the benzodiazepines, caffeine, calcium salts, Tagamet, clofibrate, the Rescriptor, as well as food, grapefruit juice, green tea, and Teresa, can you help me with the pronounce of that?
Guarana?
Guarana. I'm sorry, I always stumble over that. And hydrocortisone. Mineral oil, and I won't go on and list these, but as you can see, they're very varied. There's a wide variety of them. The anti-diabetic medicines, the oral contraceptives decrease the hypoglycemic effect by impairing the glucose tolerance. And as we talked about, it's important to know about these when you start and stop a medicine, so you may see changes in that hypoglycemic effect. It's more common in patients receiving greater than 50 micrograms of ethinyl estradiol per day. And these patients obviously need to be closely monitored when therapy is initiated or discontinued, as well as during that placebo week. Actose, you may see a decrease in the oral contraceptive effectiveness because it increases the metabolism of estrogen. Beta may reduce the rate and the extent of absorption of the oral contraceptives. You would want to take the oral contraceptive at least 1 hour prior to the beta injection. The antihypertensives can induce fluid retention. Estrogen can reduce the fluid retention and may increase the blood pressure in some patients. So you would want to monitor these patients to confirm the target blood pressure is achieved. Lipitor and Crestor are the statins that are listed as a level 4. And of course these are indicated for high cholesterol. These may increase the contraceptive hormonal levels, most likely due to the competition for the CYP3A4 substrate. Their clinical significance is unknown. My suggestion would be to take the oral contraceptive in the morning and take the statin at night. The benzodiazepines are level 4 also, and the ones included in this are the Librium, Transine, Klonopin, Valium, and Halcyon, among others. You may see an increase in their levels, resulting in side effects. Conversely, the estradiol may enhance the metabolism of Ativan, Surax, and Restoril. So you may see a decrease in the effect of these medicines. You should observe patients for evidence of increased or decreased response and adjust the dose accordingly. The corticosteroids may potentiate the anti-inflammatory effects. I left out an important word. The oral contraceptives may potentiate the anti-inflammatory effects of hydrocortisone, and also may delay the clearance of prednisolone. You should monitor the patients taking these. There is no evidence of the interaction with dexamethasone, methylprednisolone, or prednisone. Thyroid hormones. Estrogens may cause abnormal thyroid function test results, which is important to know if a patient is being evaluated for thyroid function. Estrogens increase the serum thyroxine binding globulin, and patients so may have a decreased clinical response to the free thyroxine levels. Thyroid hormone dose adjustments need to be made as necessary. So monitoring these patients is important. The tricyclic antidepressants, estradiol may decrease the metabolism of the tricyclic antidepressants, thereby increasing their serum concentration and their side effects. Imipramine side effects can be increased. This interaction is more significant and probable when doses of 50 micrograms or greater of estradiol are given per day. So the neuromuscular blockers, you may have prolonged blockade occurrence. Tagamet reduces hepatic clearance of estradiol, so you need to monitor the patients for side effects. Actigol, the oral contraceptives may increase hepatic cholesterol secretion and increase gallstone formation, thereby counteracting the effectiveness of the Actigol. Surzoin is indicated for depression. It inhibits the CYP3A4 isoenzyme, so you may have an increase in estrogen-related side effects. This is theoretical. The clinical significance is unknown. Rescriptor is indicated for HIV infection. You may have an increase in the serum concentration of the estradiol, but the clinical significance is unknown. So this leads us to question number 4. True or false? Patients should always be asked what prescription medications, vitamins, herbals, and over-the-counter medications they are taking. True. Most people do not consider the vitamins or natural products as part of their medication regimen, but these can affect how their medications work and have an impact on the dose that they need. Grapefruit juice. We're probably all aware that patients taking statins should not drink grapefruit juice, but it also decreases the estradiol metabolism and may increase the levels up to 30%. Clinical significance is unknown, basically because it hasn't been studied very much. Vitamin C or ascorbic acid can increase the estradiol bioavailability up to 50%. So you may see an increase in the estrogen-related side effects. Calcium salts estrogen may increase the calcium absorption. Caffeine, which includes the coffee, green tea, colas, chocolate, all of that contains caffeine. And you may have an increased concentration of the caffeine, so you'd have related side effects. Mineral oil. I did not realize mineral oil was used so much these days, but evidently it is. If you give it at the same time of the oral contraceptive, you'll have decreased absorption. So you need to separate the doses by at least 1 hour before or 2 hours after the mineral oil. So this concludes the first section. Do we have any questions?
Not that I'm aware of.
Okay.
Is it breakdown? Do you have any questions for us, Beth? Computer died. Okay, we're going to do some CPR on the computer, and we will be back in a moment. Let's take about a 15-minute break at this time, and we will come back and conclude our program discussing the drug-drug interactions of seizure medications. So come back, and we will finish up shortly.
We did have a question during the break, and I wanted to make a clarification. The research that I did on oral contraceptive is with the combined estradiol-containing product. I did not research the progestin only, which I understand is used quite extensively in the county health departments.
It is.
And so when you're looking at these interactions, it is mainly with the estradiol component of the combination product. Also, my research came from clinical pharmacology, which is a great resource if you have access to it. You can click on when you pull up a drug, you click on drug interaction, and it lists all the drug, and then you can sort it by severity. And it will, when you click on the drug, it will take you right to the point of the discussion of that particular drug, so there's not a lot of searching going on. If you don't have access to clinical pharmacology, Aprepitant is a very good alternative. It can be downloaded to a laptop or an iPad, and it's free. There is a more detailed version that is by subscription, but it's a good handy product. You don't have to have internet access once you download it, so it can always be available on your laptop or your iPad. So those are two really good resources, and those are the two that I pulled most of the information that I found.
Do you think it would be beneficial for us to just kind of do a very brief, short recap of the content that we covered this morning, and then we'll move into part 2?
Okay, be glad to. With the oral contraceptives, the main interaction comes from the hepatic enzyme inducers or inhibitors. And while none of us can remember which way all of those drugs go, if you have a basic understanding of what an inhibitor or inducer does, you can more likely anticipate what drug or drug-herbal interaction that will be. There are the 4 levels. Level 1 you really need to avoid unless it just cannot be avoided. If there's no other therapy out there to treat, but you really have to monitor those patients. Level 2, you certainly need to avoid, if at all possible. Consider alternative therapy. If that's not possible, monitor the patient. Those interactions are just less severe than level 1. Level 3 affects some subgroups of patients, and those are very difficult to predict. So you may consider an alternative therapy, but more importantly, monitor those patients. Level 4 is not clinically known the impact of those interactions. It's good to avoid them if at all possible, if there's a good alternative, but certainly monitor those patients to see if there is some clinical effect.
Thank you. Let's switch gears a little bit and move into the second portion of our program. And the second portion of our program is entitled Drug-Herbal Interactions and Seizure Medications. Miss Nancy?
The first drug on this we want to talk about is Gabapentin, otherwise known as Neurontin. There are other trade names for it now. It's indicated for the treatment of partial seizures. It does have high lipid solubility, but the good news is it is not metabolized by the liver. So there's no protein and there's also no protein binding. There's no enzyme induction related interactions because it is not metabolized by the liver and it does have no protein binding. It does not interfere with the serum concentrations of other medications used for seizures, and the other medications, seizure medications, do not interfere with its concentration. Therefore, there's no level 1 interactions. There are a couple of level 2 interactions that are significant that we need to talk about. The first is antacids. The aluminum containing and the magnesium containing antacids, otherwise known as Maalox and Mylanta. When these are used together with the Neurontin, you can decrease the bioavailability by up to 20%. So it's really important to take the gabapentin or Neurontin at least 2 hours after the antacid. Ethanol can also interact with gabapentin. It's a significant interaction when you use the extended release gabapentin because it releases that one faster. So you have an increased risk of side effects, including drowsiness and dizziness. Patients taking the extended release gabapentin should avoid alcohol consumption. If that's not practical for that patient, consider switching them to an immediate release gabapentin. Renagel also can interfere with gabapentin. Renagel is used to maintain the phosphorus levels in dialysis patients. And it has the potential to reduce the drug absorption. You should separate the dose of gabapentin at least 1 hour before or 3 hours after the Renagel. The Renagel. And that is all the level 2 interactions with gabapentin. As you can see, this is a very good drug when it comes to interactions, and it would be a good practical drug if it is appropriate for seizure control for your patient. Level 3 interactions, and these are the ones that the group of patients that may have a problem with interaction is unpredictable. So the patients need to be monitored. Morphine can cause an increase in the gabapentin concentration. So you should monitor these patients for CNS depression and adjust the dose as necessary. This is another one of those cases when the morphine is started and stopped. You really need to look at your dose of gabapentin and see if there's any adjustment needed in that. Closely monitoring those patients is important. I'm sorry, I skipped naproxen. The clinical significance of naproxen or naproxen is unknown, but it has been shown in one study to increase the amount of gabapentin absorbed by 12 to 15%. So separating those doses would be a good idea just because the clinical significance is unknown. Hydrocodone is another pain reliever, and it may decrease the concentration. Gabapentin may decrease its concentration and increase the concentration of the gabapentin. So we've got a two-way interaction here. It is gabapentin dose dependent, with lower doses having less effect. You should monitor the patients and adjust the dose of each. Again, starting and stopping or increasing the dose of the hydrocodone may impact the clinical effect of the gabapentin. Welchol is another medicine that it can affect the absorption of gabapentin. So you should take gabapentin at least 4 hours before taking Welchol. So the level 3 interactions. These may increase or enhance the CNS depression, so you may see more drowsiness and dizziness. Medications used as sedatives, hypnotics for anxiety fall in this category, as well as the antipsychotics. And I have a list of them there. The more common ones that you may see are the Haldol, Zyprexa, and the Risperdal. And Seroquel is also in this group. Anti-Parkinson disease medications. Also are in a level 3. And Mirapex, Recrip, Tasmar, Escomtan are listed here. Soma and Robaxin are also level 3 interactions, as well as the phenothiazides and tricyclic antidepressants. Tramadol, the sedating H1 blockers like Benadryl, and any opiate antitussive or expectorant combination. We talked about the hydrocodone and the morphine. Those products can be found in combination syrups and also oral solid forms for cough and to break up mucus. So we need to be aware of what's in that product because it could be a level 3 interaction. So as you see, there's not near as many interactions with a gabapentin, but that brings us to the level 4. Tagamet, which is not used a lot since the newer acid reflux medicines have come out, but the gabapentin clearance is reduced. We don't know if this is clinically significant just because of the lack of studies. But Inderal, the higher doses may induce dystonia, so it's very important to monitor the patients and lower the propranolol dose if necessary. So that brings us to another seizure medication, Lamictal. It's indicated for partial seizures and tonic-clonic seizures, and it has an off-label use in absent seizures. And it is metabolized by the glucuronidation. And so we really need to be careful when we add or discontinue medications once seizure control has been achieved. Again, there are no level 1 interactions with this drug, but we have a couple of significant level 2 interactions. Tylenol. When you use dosage greater than 900 milligrams 3 times a day or more, the clearance of Lamictal is accelerated by 15%. So a patient may lose seizure control if they're taking high doses of Tylenol. So this is something that a patient may not put on their drug list, but it does need to be asked about. One of the Ranazaz, I'm sorry, I'm stumbling over the pronunciation of that drug. It increases the metabolism of the Lamictal, and so you would need to adjust the dose when you add or discontinue it. The next drug we want to talk about is Tegretol, carbazepine. You may stimulate the metabolism of the Lamictal, and this decreases the level as much as 40%. While we didn't see an interaction with the previous drug we talked about, the Neurontin, with other seizure medicines, we do with this one, with the Lamictal. And there's clonazepam can increase its concentration by 3-fold, which is significant, and you may lower your seizure threshold, and it is dose dependent. So you can see by what we've discussed so far with the concentrations going up and down of the seizure medicine, even medications in the level 3 interactions can be significant if a patient loses seizure control, or if they begin experiencing side effects from their seizure medicines. They may stop taking them. DDAVP, you have an increased risk of water intoxication with hyponatremia. You may not see this drug much with someone taking Lamictal, but it is a significant interaction. Solantine reduces the serum concentrations of Lamictal up to 70%. So you can see you really want to be cautious when discontinuing this medicine. This is one that if there's an alternative therapy, it would be a good idea to look at that. Rifampin can increase Lamictal clearance, resulting in decreasing anticonvulsant efficacy. So again, you would, as you stop and stop medicines, you would need to consider this. The Renagel has the potential for reducing absorption. We need to separate the doses 1 hour before or 3 hours after the Renagel. Oral contraceptives are level 2, as we discussed in the previous section. You need to closely monitor to see if there's any change in clinical effect. The estrogen may increase the Lamictal clearance. So you may have increased side effects during the off week. The clinical significance is unknown, mainly because of this. It just has not been studied that much. So consideration of limiting these changes, go into a changes, even though, let me start all over, get my wording right, even though we don't know how this will affect, and there could be an increase in the side effects during the off week, the manufacturer does not recommend changes just for that 1 week, changes in dose just for that 1 week. But you may want to consider a progestin-only contraceptive or an extended cycle combined hormonal contraceptive. Phenytoin and fosphenytoin, other seizure medicines, do interact with the Lamictal by inducing that hepatic enzyme again. When added to the regimen, it can reduce the steady state concentration of Lamictal up to 50%. So when adding or discontinuing these medicines, please consider this in dose adjustments. Barbiturates, the phenobarbital, can induce the hepatic enzymes. It can reduce the steady state concentration of Lamictal up to 40%. Again, needing a dose adjustment. The oxcarbenzapine, you have an increased clearance up to 29%, so you should monitor for headache, dizziness, nausea, and somnolence. Other seizure medicines that fall into level 3 are the valproic acid, and this more than doubles the elimination half-life and steady state concentration of the Lamictal. So adjust the dose if the valproic acid is discontinued. Topamax, another drug used for seizures, can have its concentration decreased by the Lamictal. Clinical significance is unknown, but using these two medicines together, especially when one dose is increased or decreased, needs to have careful monitoring of the patient. Bupropion or Wellbutrin, it's actually a drug-disease interaction, and it should not be used in patients with a pre-existing seizure disorder. Ritonavir increases the hepatic metabolism, resulting in decreased Lamictal concentrations. A dose increase of a Lamictal may be necessary. This is one of the HIV protease inhibitors. Dihydrofolate reductase inhibitors, such as the 5-FU methotrexate, trimethoprim, all inhibit the dihydrofolate reductase. So these should be used in caution. And just as a reminder, the trimethoprim is a medication found in Bactrim. We talked about the well call and that we need to give the Lamictal at least 4 hours before it because of absorption issues. And that brings us to Topamax. The Topamax is indicated for partial seizures, tonic-clonic seizures, and the Lennox-Gastaut seizures, which I hope I'm pronouncing correctly. It is metabolized minimally by the liver. It is a minor CYP3A4 inducer and a weak CYP2C19 inhibitor. Again, those are hepatic enzymes, and it's not necessarily to remember all of those words and initials and letters, but just to know that the liver enzymes are affected and cause some of the drug interactions with this medication. So alcohol consumption should be avoided. alcohol withdrawal or excessive use may lower the threshold, the seizure threshold. And because that is unpredictable, it is probably necessary to tell patients taking Topamax to avoid alcohol altogether. Topamax you should avoid doses over 200 milligrams per day if you're using hormonal contraceptives, and we discussed this in the previous section. Level 1 interactions with Topamax. Benzocid, you probably won't see a lot of that, I wouldn't think, but there is a significant increase in the renal clearance of the Topamax. So your Topamax levels are lowered. There are no human trials showing this, but it has been shown in animal trials. So that brings us to the level 2 interactions with the Topamax. Metformin, glucotrol, this glucophage. This is a significant interaction because it can cause metabolic acidosis and may increase the serum concentration of the metformin. It's best to avoid taking both, but if absolutely necessary, you really need to monitor that patient's blood sugars. We talked about the oral and non-oral contraceptives because Topamax does increase the clearance of the estradiol, and it is patients at more at risk are those taking more than 200 milligrams a day of the Topamax. Okay, alcohol or ethanol, it alters the pattern of the Topamax extended release. So we don't want to take these, consume at the same time. We tell the patient not to consume alcohol within 6 hours before or after taking the Topamax. And because patients normally don't think about this, it would be best for them to avoid the alcohol altogether. Topamax can decrease the dolutegravir levels. This is another one of the HIV protease inhibitors. So you can see a decrease in the level of that medication. Tramadol, Topamax can cause some CNS depression and cognitive and or neuropsychotic or psychiatric reactions. So you're also decreasing your seizure threshold. This is probably not a great drug to use with Topamax. Alternative pain medications should be considered. So the hydrochlorothiazide, or HCTZ, is also a level 2 interaction with the Topamax. And this can potentiate potassium wasting. Its clinical significance is unknown, but it may require a reduction in the dose of the Topamax when the hydrochlorothiazide is added or the dose is increased or it is discontinued. You would want to monitor the potassium levels on these patients when adjusting these doses. The carbonic anhydrase inhibitors, you can have increased risk of renal stone formation, and you can also have increased risk for heat-related disorders such as heat stroke. That would be an important information to have in the Alabama heat in the summer. You would really want to tell these patients to avoid the outside during the summertime, especially extended periods outside. If patients have a job that requires them to be outside, you might want to consider a different medication or avoid this interaction. You have an increased risk in bleeding, and I've listed the drugs that these include. This acetazolamide and the methazolamide are included in this. The telithromycin you can have subtherapeutic levels of it when you take it with Topamax, so that would result in decreased efficacy. It can also have increased serum concentration of the Topamax, which would result in the increase of adverse effects. We talked about the renal gel. You have potential for decreased absorption of the Topamax, which would have a loss of efficacy. So you really need to separate those doses at least 1 hour before or 3 hours after. The linagliptin, you may have decreased levels to take it to subtherapeutic, so you really need to consider a different medication if a patient is on Topamax. And another level 2 interaction is a valproic acid. You can have, which is another seizure medicine. You can have decrease in valproic acid and Topamax concentrations. And you can also have, it can also be associated with hyperammonemia. If you have a patient that's exhibiting some unusual behavior, you might want to do an ammonia level on them, because this drug interaction can be very significant and very troubling to the patient and their family. It also can be associated with hypothermia and increase the risk of bleeding. Your level 3 interactions, the amitriptyline, your anticoagulants, antimuscarinics, aspirin, barbiturates, benzodiazepine, and carbenzapine. We have some more listed here. I think you'll find there's several in this category. So you can refer to your handout or your slides to list those. And then we go to the level 4. Let me look over the level 3 just for a minute and see if there's anything significant. There is one I'd like to refer to, a couple actually. Aspirin is one of those. And so this is another drug that patients may not tell you that they're taking. And if they take it sporadically, you'd need to know this, because you may see some change in the efficacy of the Topamax. And we also see the estrogens listed in there, as we discussed earlier. There is several of the HIV protease inhibitors in this group. And as well as the NSAIDs. So again, these are, if a patient takes ibuprofen or naproxen at home, you might want to make sure that that's on their medication list. They may not think about putting it on there, so it needs to be asked about. It can change your Topamax levels, so you may lose seizure control or have increased adverse effects if they use these drugs consistently. The opioid agonists are on here. hydrocodone, those type things. Metformin and your Actose. You can have changes in your blood glucose levels, so that certainly needs to be monitored. Your platelet inhibitors, you want to make sure that the patient is watching for signs of bleeding.
SSRIs.
The SSRIs, certainly. A lot of patients are on those for depression, so those would be a significant question to ask if you have a medication profile that lists those. So that takes us to the level 4 for Topamax. And the VFin is an antifungal. Taking Topamax can increase the concentrations of it. Clinical significance is unknown with this. So that takes us to our next drug, Lyrica. It's indicated for partial seizures. There's no drug interactions of clinical significance due to the inhibition of the CYP3A4 enzymes that has been reported. There are no level 1 or level 4 interactions. One interesting fact is that raw ginkgo seeds can decrease its efficacy. Again, this is something that a patient may not put on their medication list, but if you have a patient on Lyrica, you might want to ask about it. Level 2 is the interactions with Lyrica are the angiotensin converting enzymes. These may cause life-threatening angioedema with respiratory compromise. So obviously you need to pay special consideration before starting a patient on Lyrica if they're on an ACE inhibitor, or if they're on an ACE inhibitor and you want to start them on Lyrica. You may certainly want to consider alternative therapy. Examples of ACE inhibitors: Acupril, Benzapril, Enalapril, and Lisinopril.
All those Pril medicines.
Right. And I have a really tough time keeping all these heart medicines mixed up, so that's the way I remember them.
The Pril medicines?
The Pril medicines. The level 3 interactions, the diabetic medicines that are the I'm not even going to try to say it. I'm stumbling right now over words, but it's the Actose group of medicines. There's a higher rate of peripheral edema and weight gain in these patients, and it may exacerbate or lead to heart failure. These medicines have been in the news recently because of their effects on the heart, so you really may consider alternative therapy if you have a patient that you want to start on Lyrica, or consider a different diabetic medicine. You can potentiate the CNS effects with the following medicines, and this may involve the sedation, the cognitive, or the gross motor function. The opioids, the hydrocodone, morphine, those medicines are included in this. Again, the alcohol, the phenothiazines, as well as the sedating H1 blockers, such as the diphenhydramine.
That's the same thing as Benadryl?
Benadryl.
Benadryl,
that's right.
Okay.
The medicines used for anxiety or as a sedative, a hypnotic, are included in these. Barbiturates. The other medicines you probably won't see, but do look at the last one, THC, which is the ingredient found in marijuana. Again, the patient will not put marijuana on their medication list. Probably one of the questions you ask is, do you use any type of street drugs? This would need to be considered if they do list marijuana use on their profile. These are other medicines that are found in the level 3 interactions of Lyrica. The tricyclic antidepressants are something to be considered, but as probably all of you remember from school, tricyclic, those antidepressants interact with most everything.
Yes.
So anytime a patient's on those, you need to really monitor the patient or consider alternative therapy. The levodopa is also on this list. And that takes us to valproic acid or the divalproic sodium. And these really are the same medicine. The divalproic sodium is actually just the sodium salt of valproic acid. So we're going to use those terms interchangeably. They're indicated for absence, myoclonic, partial, and tonic-clonic seizures. Excuse me 1 second, please. There are no level 1 interactions with valproic acid. It's metabolized by hepatic CYP450 enzymes, as well as the CYP2C119 and the CYP2C9. Therefore, the interactions can be significant. Ginkgo may decrease the seizure efficacy, anti-seizure efficacy of valproic acid. So again, this is probably not something they would put on their drug profile, but it doesn't need to be asked about. And two of the other drugs may increase the risk of bleeding. So you need to make sure that if these drugs are on their profile, consider that. You can have increased risk of CNS effects and other adverse effects with the duxalamine. And the carbapeniums are a level 2 interaction. These are the imipenems. These are anti-infectives, and you probably wouldn't see these except in a hospital, I would think. So, but it does need to be considered, and you may have a decrease to subtherapeutic levels of your valproic acid. Carbazepine can increase the clearance and decrease the concentration of the valproic acid. So you want to make sure if they're taking these two anti-seizure medications that you are monitoring this, and if there's a dose change in one or the other, take that in consideration. You may decrease the metabolism of the carbazapine's active metabolite, which can cause vomiting and tiredness, and this is especially true in children. Level 2 interaction, rifampin. This is something you may see. You have an increase in the clearance of both the valproic acid and the rifampin. So you'll need to adjust the dose of the valproic acid as necessary. Again, the consideration of adding or stopping, changing dose of any of the two drugs that cause interaction should be considered when a patient presents taking both or you're considering adding a medication. Isoniazid may inhibit the valproic hepatic metabolism, and so you may have increased concentrations, and that could lead to hepatotoxicity. Topamax with the valproic acid can cause the ammonia, increase in ammonia levels that we discussed, and the hypothermia. So again, you'll need to, if a patient presents with unusual symptoms, you might want to draw an ammonia level, and you may want to counsel them to stay out of the really cold weather, such as we have periodically in Alabama. You can have, this interaction can cause additive CNS depression and can lower your seizure threshold. Again, paying very careful attention to the doses when you add and take away. Other medications in this level is the Haldol, the monoamine oxidase inhibitors. Again, one of those groups that everything interacts with. So if you have medications in this group, you want to consider your dose and maybe alternative therapy. The level 2 interactions continue with your protease, HIV protease inhibitors. You can decrease your valproic acid concentration and efficacy. Again, watching for seizures. If taking these two drugs is unavoidable, you need to monitor your seizure threshold, your seizure level. Sodium oxybate can increase the systemic, valproic acid can increase its systemic exposure, may impair attention and memory tests. So if you have an older patient that you're evaluating, this may be a consideration. The dose, you may want to reduce the dose up to 20% if valproic treatment is initiated. You should obviously closely monitor the patient and make dose adjustments if necessary. Cholestyramine, it decreases the bioavailability of valproic acid. You should separate these doses at least 2 hours before or 8 or 6 hours after the cholestyramine. The Renagel, again, for this medicine you have potential for reduced absorption, separating the dose by at least 1 hour before or 3 hours after the Renagel. Other three level interactions with the valproic acid include the barbiturates, the bupropion or Wellbutrin. The alcohol is listed in here, and again, another consideration. You have the Lamictal listed here. Again, the NSAIDs show up, as well as salicylates. These are drugs that may not be on the patient profile because they take it intermittently, or they may be taking ibuprofen or for arthritis and just don't really consider it a drug since they don't have to have a prescription for it. But it should be asked about. The tricyclic antidepressants and the Warfarin, Coumadin, INR levels should be drawn, especially if doses are increased or decreased. And patients should be counseled, if they are on warfarin, to watch for bleeding and, again, monitor those INRs. Then antacids show up. Again, that's an absorption issue. So separating those doses by at least 3 hours would be the best thing to do. Diazepam and lorazepam. Many patients are on these for various reasons, anxiety, or the Valium could be a seizure medicine also. So that brings us to Keppra. Let me catch up here. Okay, Keppra is used only in combination with other seizure medicines, and it's used in partial myoclonic and generalized tonic-clonic seizures. There's minimal interactions with other seizure medicines, There's no drug interactions with commonly prescribed medicines, and it's not an inhibitor or has high affinity for the hepatic P450 enzymes, and there are no level 1 interactions. There are a couple of level 2 that we need to talk about. The Renagel, again, for the reduced absorption and separating the doses is necessary for taking this. Probenzen is a major metabolite of Keppra, was actually approximately doubled when taking it with this drug. So your renal clearance can decrease up to 60%. Clinical significance is unknown, but just given those numbers, you really need to monitor patients if it's necessary to put them on this drug. Level 3 interaction is alcohol again. You may lose seizure control, and you also may increase your drowsiness and dizziness. So the enhanced effects of the alcohol would be considered. Again, with the well call, you've got altered Keppra concentrations. You need to separate the doses. It's again an absorption issue, so doses need to be separated at least 4 hours. So with the carbamazepine, I'm losing concentration on these generic names, you have your pharmacodynamic interaction. So the toxicity symptoms, and especially the ataxia, the unsteady gait, has been reported, and it's usually in doses that are equal to or greater than 500 milligrams a day. And this brings us to Dilantin. Now, Dilantin is used, it's FDA indicated for tonic, clonic, and partial seizures. It's not used to a great extent today because of the newer medicines that have fewer drug interactions. And Dilantin has a very narrow therapeutic index. So any interaction can really cause it to be subtherapeutic or into toxicity. So anybody on Dilantin really need to look at the other drugs they're taking, as well as their over-the-counter medicines. It does inhibit the P450 enzyme system, and the interactions, as we talked about, can be very complex and can be unpredictable at times. Interactions can be influenced by the patient's age, presence of liver disease, and their cigarette smoking history, not just present smoking history, but if they have smoked in the past. Has several level 1 drug interactions. I'm not sure how much time we have to go through these, but the main thing to take away is that if you do have a patient on Dilantin, look at the drugs, other drugs that they're on. Some of the HIV protease inhibitors are on this list, and nifedipine is a commonly used drug that is on the list also. So as we said, these drugs can really change the therapeutic index of Dilantin. It would be best to use alternative therapy. That may not be possible. So the patients need to be closely monitored, very closely monitored. There are over 70 drugs listed as having the potential for level 2 interaction with Dilantin. These include the oral and non-oral contraceptives, rifampicin, isoniazid, and the protease inhibitors. Again, we saw some of the protease inhibitors on level 1. Alcohol, fluconazole, St. John's wort, and the vinca alkaloids. So these medicines Obviously, you need to monitor patients if there is alternative therapy available. That would be a great idea. St. John's wort and the vinca alkaloids would probably not be something that would be on the drug profile of a patient, so it needs to be asked about.
Can you give us a couple of examples of what might we see with a patient that wrote down some vinca alkaloids?
I didn't. I'm sorry, I don't remember that, but I can certainly look that up and get back to you with that. I don't. There were so many in this category. I didn't look up each one individually, but I'll get back with you on that. And there were 70 drugs on the level 2. There's over 90 on the level 3.
Wow. So,
as you see, Dilantin is just a drug that is very, patients need to be monitored very, very closely with it. The drug profile needs to be assessed very closely. Some of the examples on this are the antacids that we talked about earlier, the PPIs, such as Prilosec and Nexium would be on that, and those are very common drugs for people to be on. People may not tell you that they're taking the antacids like Mylanta or Maalox, so that would need to be asked if you have a patient on Dilantin. Miconazole and Cipro. Cipro is one of those drugs that if you have a patient on Dilantin, you might not have a lot of choice of changing a patient or using a different drug other than Cipro, depending on the susceptibility report. So you would really want to draw that phenytoin level and monitor if they're going to be on Cipro for a long time. That needs to be monitored to make sure that their Dilantin dose needs to be altered. The estrogens and the opioids, the sulfonamides are all on this. These are very common drugs. Sulfonamides, of course, are antibiotic class. Keflex, that class. So if you have a patient that has an infection, you really want to monitor signs for that Dilantin therapeutic level going up and down. Trimethoprim is in Bactrim, so that's another anti-infective. Vitamin D, most physicians now are telling their female patients to take vitamin D. So it may not be on their medication list, but it would need to be asked about. There are over 30 drugs as having level 4 interaction with Dilantin. And some of these that you might see are the Tylenol, acetaminophen, acyclovir, the anti-diabetic medications, and caffeine. Caffeine, obviously, probably everybody takes caffeine through their tea or coffee, but it needs to be consistent. If they're on Dilantin, they need to take a consistent amount of caffeine a day so that therapeutic index the therapeutic level will not go up and down. The concentration won't go up and down outside and inside of the therapeutic index.
So if you're a 3-cup-a-day person, then you need to stay at 3
cups a day. Right.
Okay.
You need consistency. And this is much like the Warfarin, which also has a narrow therapeutic index. People, this is just a side note, but green leafy vegetables, Warfarin patients are told to avoid those. Well, not many people are going to avoid all green leafy vegetables. So what we tell them to do is be consistent. If they love turnip greens, eat turnip greens, the same amount of turnip greens on Tuesday every week, just so that it is consistent. Other level 4 interactions with Dilantin that you may see is the folic acid, green tea, aspirin. and the one I could not pronounce, the
Garanta.
And as well as the flu vaccine, which I found very interesting.
Yes, that is interesting.
You wouldn't want to hold the flu vaccine out, but you would want to monitor the patient for toxicity or coming out of that therapeutic level.
Let's do a little recap, Nancy, of what we've covered a lot of material this second half for this morning. So some takeaway points for this morning. What would you like for the audience to take away from your second half?
The anti-seizure medicines we have much more choice than we used to have. There's many new drugs, and there's some old drugs that are getting the FDA-approved indication for seizures. So we have a lot more choice than we did in the past. We have some medicines that have no level 1 interactions, and some that one in particular doesn't affect the hepatic enzymes. Those are really good choices. When you have a patient that is on steady state, they've got their anti-seizure medicines, they're not having loss of seizure control, and they're not having the toxicity effects. When you add and take away medicines, you could disrupt that. So if you have a patient that presents to the clinic on a seizure medicine, do some research. See how it's going to affect that drug. It could cause increased toxicity, or it could increase the side effects, or it could lower the seizure threshold, so they may experience a seizure before they were in total control. So there are a lot. We did cover a lot of material, and the best thing to do is not try to memorize it, but just try to look it up if you have a patient that's does present. One of the interesting studies or articles that I read about Dilantin is a patient presented to the hospital with some unusual effects. And they couldn't figure out what was wrong with him, and he was a known cocaine user. And so by chance they did a phenytoin level, and he was in toxicity, though he was not on Dilantin. Phenytoin is actually used to cut cocaine. And I did not know that.
I did not know that either.
So if you have a patient that appears to have phenytoin toxicity and is a known cocaine user, that's something you might want to look at, draw a level to see.
Very interesting.
So
We do have 2 questions.
okay.
We've got a couple of questions. Miss Beth, will you take those? Will you read those for us?
Sure. The first question is, what are some of the most common symptoms of drug or herbal interactions to oral contraceptives or seizure medications? Which I'm sure that part of that has to do with when you're talking about what you're treating, of course, the seizure medications is one of the things they're asking about. So if it decreases the effectiveness of the seizure medication, then your symptom's going to be more seizures. But what about like it just says most common symptoms of drug or herbal interactions to oral contraceptives or seizure medications?
Well, like you said, the seizure medicines, you may experience seizures where you were well controlled in the past, or you may have the toxicity effects, the dizziness, sedation, that sort of thing. With oral contraceptives, you may, if you have failure, obviously the patient could get pregnant. But if there's changes in the bleeding patterns, there's increased bleeding, that's something you would want to consider looking at your drug interactions.
Okay. Another question was, do you have any examples of how serious an interaction can become, and what factors increase the chances of one occurring? I mean, that depends on what medication you're talking about.
Right, and that's why medicine is not an exact science. Every person is different. The way our bodies process medicines, metabolize medicines is different. So what you see in one patient, you may not see in another. And that's what makes these drug interactions so unpredictable. And we can't guarantee that one person would have a level 1 or level 2 interaction symptom. But it's certainly something the patient needs to be monitored, and if symptoms do come up, look at the drugs and over-the-counter medicines, the herbals, and see if there's an interaction that does exist.
Okay, and we do have a phone call.
Caller, are you there?
Yes.
Good morning.
Good morning.
Go ahead with your question, please.
I have a patient who has called and asked me about taking flaxseed with her oral contraceptive. And when I did some research, it does say that flaxseed can act like the female hormone estrogen. It can compete with the estrogens that are in the birth control pills. And so healthcare providers are a little bit concerned that the flaxseed might make the estrogen-containing pills less effective.
And I did not find that in my research, so thank you for bringing that out. But again, that's one of those things that patients may not put on their drug profile. And so that is very interesting. We need to add that to our list.
We do.
Thank you very much.
Thank you.
And could you please mention again the resource, I believe you said Aprepitant,
right,
the free app?
Yes, most of the information I got today was from Clinical Pharmacology and Hippocrates. Hippocrates is, you can download it free, and it's basic information you can find out how the drug works, the interactions that are listed for that drug or have been researched for that drug, and it's just a great resource. There is a more detailed subscription you can get for it, but I have found the free download just wonderful. And if I write that out, I can tell you how to spell it. It's EPOCRATES.com.
Mm-hmm. Very good resource. It'll give you the dosages as well as both names and,
right,
like you said, frequent interactions of different types of medications, foods, herbals, those types of things. We have those loaded on our iPads that we use when we work in the pods, the point of dispensation arenas as well. So they are wonderful. And
it also has a medication identification in there.
It does.
So that if you have a pill that you need to identify, you can enter any description of it as well as the imprint on it.
That's important. Perfect. It really is. I want to thank each of you for your time and attention today. We've covered a lot of material, but please be sure to do your paperwork, your evaluations, your sign-in sheets. The slides will be available to you to download if you so choose to do that. We would like to thank Nancy again today for her time.
Thank you for having me.
And thank you very much for being here, being with us. We appreciate it very much. Miss Beth, do you have any closing comments for today?
I think so. I appreciate you doing this for us. It was very informative. Thank you very much.
Check the calendar frequently as we have several more programs upcoming in the very near future. The website will be available to you to check those resources, but please feel free to do that. And we thank you again for your time.